Good morning. So over the next 30 minutes, I'm going to discuss CAR T-cell therapy in lymphoma. These are my financial disclosures. What I hope to cover is a brief history of CAR T-cell development, and then discuss where we are with CAR T-cell activity in lymphoma, and then touch on what we have learned of relapses and resistance and development of toxicities, both what we learned on mechanisms and management of these toxicities. I think it is important to note that the concept of CAR T-cell therapy is old. It was first described in 1989 by Zelig Eshar and colleagues from the Weizmann Institute. At that time, it was referred to as T-body, T-cell receptor, and later the term chimeric antigen receptor. And a chimeric antigen receptor is a synthetic protein. It binds the antigen binding domain of a monoclonal antibody to the signaling domain of a T-cell, and hence the name chimeric. And thus, it combines the specificity of a monoclonal antibody to the cytotoxic machinery of a T-cell. And the first generation CAR T-cell that was developed in 1989 included a CD3 zeta T-cell receptor signaling domain. This CAR went to the clinic and had very modest activity in clinical trials. And it wasn't until the mid-2000s when we learned that the T-cell actually needs a second signaler to be activated. And that led to the birth of what is called now second generation CAR T-cell, either using CD28, 41BB, or other co-stimulatory domains. And I mentioned that because the FDA approved the products are second generation CAR T, either using CD28 in the case of Yescarta or Axicell, or 41BB in the case of Kymriah or tisagenlecleucel. And since then, several investigators have tried adding further co-stimulatory signals, led to the birth of the third, fourth, and fifth generation CAR Ts. But so far, it does not seem to be that adding more signals add to the CAR T cell activity. And the process of CAR T cell is complex, as we're going to go through this in patients with lymphoma. Patients undergo apheresis. The cells are shipped to the lab, either at a local lab or in case of the FDA-approved therapy to the pharmaceutical company. The T cells are stimulated and they are engineered with a virus in case of the FDA-approved therapy, but also can be engineered with non-viral technologies. And they are expanded in the lab over a period of 10 days or so. By the end, many of the T cells, or most of the T cells, are now CAR T cells, and the T cells have expanded by several folds. Then the CAR T cells are frozen, and they are shipped back to the patient. Patients receive lymphodepleting chemotherapy, low-dose chemotherapy, followed by infusion of the CAR T cells. And the first successful report of CAR-19 was in one patient of follicular lymphoma and the 3 patients with CLL. The patient with follicular lymphoma was from the NIH, published in 2010, and the 3 patients with CLL published in 2011 in New England Journal of Medicine from the University of Pennsylvania. While these are only few patients, it really triggered all the excitement and the promise in the field. What we learned is that the CAR Ts are quite potent, that each cell can kill many, many cancer cells, and that patients can get sick during this process, can develop cytokine release syndrome, tumor lysis syndrome, and that these cells can be quite potent. Patients go in remission, and in fact, some of the first patients that were treated with CAR T are still in remission many, many years later. The complex is a process. The process is complex, and we're going to go over this in lymphoma. We select patients, then patients receive bridging chemotherapy while the CAR Ts are manufactured. Then we select the CAR T construct, and the CAR Ts are manufactured, they are released. Patients receive lymphodepleting chemotherapy. The CAR T is infused and then develop toxicities. And we'll touch on the toxicities in this session. The common toxicities include cytokine release syndrome, neurotoxicity, and B-cell aplasia, and we'll touch on relapses after lymphoma. So in patients with lymphoma, there are no age limit that was included in the clinical trial. Older age does not predict toxicities and is not excluded from the trials or from CAR T-cell therapy. General patients were selected with good performance status for the trial and adequate functions. The two FDA-approved products are tisagenlecleucel and axi-cel, and were expected to receive FDA approval for liso-cel later this year. Tisagenlecleucel is approved in diffuse large B-cell lymphoma, high-grade B-cell lymphoma, as well as transformed diffuse large B-cell lymphoma from follicular lymphoma. Axi-cel is approved for diffuse large B-cell lymphoma, primary mediastinal B-cell lymphoma, also transformed follicular lymphoma. Both of these are approved for patients that have received 2 or more prior lines of therapy. Patients receive bridging chemotherapy after apheresis while the CAR Ts are manufactured. This is typically at the discretion of the clinician, but requiring some washout 1 to 2 weeks prior to infusion, and especially for lymphotoxic chemotherapy. And then it's important to note the differences between the constructs. The 3 CAR Ts that are in the clinic, the 2 that are FDA approved, this is tisagenlecleucel and axi-cel, and the 3rd CAR T construct, this is the liso-cel that is expected to receive FDA approval. Tisagenlecleucel and liso-cel use lentiviral vector and 4-1BB co-stimulation. Axi-cel uses retroviral vector and CD28 co-stimulation. Liso-cel is the only product that does not start with bulk T cells, but isolates CD4s and CD8s and makes CD4 CARs and CD8 CARs and expand them, so there will be 2 infusions. In all cases, the duration of expansion is 8 to 10 days. And it's important to know that the co-stimulation for 1BB versus CD28 dictate the fate of the CAR T. So when 4-1BB is included, the CAR T becomes more memory CAR T, while CD28, when they're included, the CAR T becomes more toxic initially. So when there is 4-1BB, because the CAR Ts are memory CAR Ts, the persistence could be potentially years. As I mentioned, some of the initial patients that receive CAR T, they still have the CARs circulating around. While when CD28 is included, the CARs are toxic initially, they are potent, but they do not persist as long. And then there is a question whether persistence is really important or not. And that will likely depend on the disease that's treated. It's different between lymphoma and leukemia, for example. When patients receive lymphodepleting chemotherapy, and the question comes is, how important is lymphodepleting chemotherapy? There is plenty of preclinical studies to suggest that lymphodepleting chemotherapy is actually important and that it increases the response after a CAR T. And there is also a small clinical study in patients with lymphoma where patients were either given either Cytoxan lymphodepleting chemotherapy or fludarabine and Cytoxan chemotherapy as lymphodepleting. And with the use of fludarabine cyclophosphamide, then there was increase in the complete response and the partial response. And based off that, it has become more of a common practice to use fludarabine cyclophosphamide as lymphodepleting chemotherapy. Then CAR T cells are manufactured, and prior to the release of the product, they need to undergo certain release criteria. And I mentioned that especially because viability is an issue. Viability means what's the percentage of the cells that are alive at the time of the production. And the FDA required 80% viability. And as such, some products such as tisagenlecleucel had higher failure rate because not meeting that threshold of viability. But we're learning that the viability actually does not affect the efficacy. In a recent report from the University of Pennsylvania in Blood, showing that patients that had lower viability had similar responses, suggesting that probably this is not a very important criteria. Then patients receive CAR T infusion. And the CAR T infusion could be an outpatient infusion or inpatient infusion, similar to the bone marrow transplantation, depending on the institution and the guidelines of the treating center. In some institutions, patients receive it on an inpatient-based outpatient unit, an outpatient unit within the hospital. Patients receive pre-medications, avoiding steroids, avoiding non-steroidal anti-inflammatory drugs. And in general, the institution requires 2 doses of tocilizumab to be available in-house prior to CAR T-cell infusion. And that center needs to be certified by the Immune Effector Cell Program in the United States that is managed within FACT. The question comes is, does the CAR T dose matter? And the answer is really, we don't know, but so far it seems to be that there is a threshold effect. There are 2 studies, one in CLL and the other one is multiple myeloma. So in CLL, in this study, patients were randomized to receive either 1.5 times 10 to the 7 CAR T or 1 times to the 1 to 5 times 10 to the 8. And at the end of this study, there was no difference in the complete response, suggesting that the dose does not matter. But we learned from the multiple myeloma study, as well as from significant preclinical mouse studies, that there might be a threshold effect, that when the CARs reach certain dose, that's when they are activated, when they expand in vivo, and when they induce effect. But if they do not reach that certain dose, then we don't get that benefit, that effect. You can see that in multiple myeloma, this is with BCMA CAR. You see that patients that had the lower dose, in this case 50 times 10 to the 6, there was not much of activity. But in any dose that is higher than that, there was significant activity, and there did not seem to be differences with the higher doses. In other words, when we hit that threshold, increasing the dose further does not matter in the activity. And in diffuse large B-cell lymphoma, the outcomes have been quite impressive. About 70% of patients have an initial response, but more importantly, about 40 to 60% of patients have a complete response, and about 30 to 35% have durable responses. We don't have the durable responses with an updated follow-up from the Transcend 001 study. This is the Lysocell trial. But what we learned is that patients that achieve complete response have more durable responses. These are data from both Yescarta, Axicell, as well as Chimeric, Tisagenlecleucel, the 2 FDA-approved products. And you can see that patients that achieve complete response have longer progression-free survival in both Yescarta and Chimeric. This data suggests that, remember that the main differences between Yescarta and Chimeric is that the co-stimulation is 4-1BB in Chimeric and is CD28 in Yescarta, and that 4-1BB co-stimulation, the CARs can be persisting, while in Yescarta they are more potent but not persisting. But this data suggests that perhaps persistence does not really matter in lymphoma, unlike in acute lymphoblastic leukemia, where persistence seems to play more a role. Moving to CAR T-cell toxicity, what we have learned is we've learned that after CAR T-cell infusion, we get cytopenias. Of course, the development of cytokine release syndrome, associated HLH, neurotoxicity, as well as hypogammaglobulinemia and immunization post-CAR T-cell therapy. Cytopenias are common. They are related to lymphodepleting chemotherapy, but also related to cytokine changes after CAR T infusion. In about 30% of patients, there is a prolonged cytopenias beyond day 30. There's a controversial role for growth factors, that's Neupogen or GCSF. However, there is a hesitance to use GM-CSF because of the monocyte stimulating factor. As you will see, that monocyte and macrophages play a critical role in the development of toxicities that are cytokine release syndrome and neurotoxicity. So most institutions do not recommend use GM-CSF or Leukine to help with cytopenias post-CAR T-cell therapy. Antimicrobial prophylaxis, the role is controversial. Most of this data is extrapolated from the transplant literature, but most institutions use PJP prophylaxis, antimicrobial and antiviral prophylaxis, similar to our bone marrow transplant patient population. Cytokine release syndrome is the unique toxicity after CAR T-cell therapy, as you all know. Cytokine release syndrome, almost all patients that respond develop cytokine release syndrome. It's characterized by fever, hypotension, hypoxia, and elevated level of cytokines, especially IL-6, GM-CSF, TNF-alpha, interferon gamma. And based on that, there's daily monitoring of fever and daily CRP monitoring that have become part of the standard guidelines in management of patients after CAR T-cell therapy. Cytokine release syndrome occurs when the CAR T-cells are expanding, when they recognize the tumor and proliferate by thousands folds in patients, and associated with the release of extreme levels of these cytokines. It is fairly common. See, any degree of cytokine release syndrome is reported between 58% in the Juliet trial to over 90% in the Zuma-1 trial. And also grade 3 or more cytokine release syndrome. These are patients who are in the intensive care unit, on pressors. Many of them are on the ventilator. It's in quite significant percentage of patients. And neurotoxicity is also common, which we'll touch on next. And you can see grade 3 neurotoxicity is in about 10 to 30% of patients. You can also note here that there are differences in the toxicities between the two constructs, especially with neurotoxicity, and it might be due to the fact that the Yescarta is initially more potent, more toxic, and results in a slightly higher toxicity. However, the numbers are small. In cytokine release syndrome, there does not seem to be much difference between Zuma-1 and the Juliet, between Yescarta and Kymriah. HLH is common also after CAR T-cell. This is data from the University of Pennsylvania from their intensive care unit experience. And you can see many patients, almost all patients, have some degree of elevated ferritin, LDH, coagulopathy, low fibrinogen, which have become a standard of care and monitoring in patients after receiving CAR T-cell therapy. Neurotoxicity, as we mentioned, it usually follows cytokine release syndrome. The median time of difference is 1 to 2 days between the onset of cytokine release syndrome and the onset of neurotoxicity, as you can see in this curve. And neurotoxicity is typically reversible. It's up to 70% of patients that receive CAR T-cell therapy can develop some sort of neurotoxicity. The most common presentation is encephalopathy, but confusion is common, obtundation is common, seizures can be common. Occasionally atypical findings such as transient aphasia, myoclonus, hemifacial spasms, and brain edema is seen as well as deaths have been seen with neurotoxicity. The mechanism of neurotoxicity is not very well understood, and I'll touch on that. But neurotoxicity is seen with other CAR T-cell constructs. There was some thought that it's related to CD19 expression on the brain. However, we're seeing some neurotoxicity with BCMA CAR, with CAR22, as well as with other CAR T-cell constructs. It's also seen with BiTEs, with bispecific T-cell engagers, suggesting perhaps a similar mechanism. It is correlated with CRS, and this graph, you can see that patients that develop severe CRS, grade 3 or 4 or 5 CRS, develop also severe neurotoxicity, grade 3 and 4. And it can be associated with MRI abnormalities. You can see here some transient abnormalities in patients that received CAR T-cell therapy, or permanent abnormalities in patients that develop brain edema and that resulted in death. And neurotoxicity is associated with increased blood-brain barrier permeability. You can see here that patients that develop a grade 3 or 4 neurotoxicity have significantly higher CSF protein compared to patients that develop grade 2 neurotoxicity, and that increased with the increased level of neurotoxicity. And importantly, that neurotoxicity seemed to be associated with myeloid cells and their cytokines. This is analysis from the ZUMA-1 pivotal trial of Yescarta in patients with lymphoma. And you see patients that developed neurotoxicity had the most significantly associated cytokine being GM-CSF. Furthermore, in these patients that developed neurotoxicity, you can see that patients that developed grade 3 or higher neurotoxicity had 17-fold more infiltration of myeloid cells into the cerebrospinal fluid compared to patients that developed grade 0 to 2 neurotoxicity. So in summary, what we think about the mechanism is that cytokine release syndrome, the mechanism is more well understood. CAR-Ts, they need the tumor, they proliferate, they produce high level of cytokines, and it's more of a capillary leak syndrome. And neurotoxicity is following this cytokine storm. We know that there's a blood-brain barrier, and there is CNS cytokines. There's myeloid cells, maybe there are T cells into the CNS and microglial activation, and that results into the development of neurotoxicity. Treatment of CRS and neurotoxicity is mostly supportive, often in the intensive care unit. The use of seizure prophylaxis is common, however, it's unclear how much that helps. And the use of steroid and tocilizumab are common. Tocilizumab is an IL-6 receptor antagonist. It rapidly reverses cytokine release syndrome. It's usually administered between day 2 to 11, and timing of tocilizumab is important. And tocilizumab works. As you can see here, this is a graph from one patient, and you see the temperature is 103, and within hours of using tocilizumab, the temperature goes down and cytokine release syndrome is reversed. But because there is concern on when to administer tocilizumab and whether to use it early on or to reserve it to the severe cases, there have been several grading systems for cytokine release syndrome and neurotoxicity, which is now referred to as ICANS. And the most commonly used grading system is the ASTCT or ASBMT consensus guideline for both cytokine release syndrome and neurotoxicity. And you can see that grade 3 cytokine release syndrome, where the use of tocilizumab is generally recommended, is that when patients require vasopressor or patients have significant hypoxemia. However, we are moving into using tocilizumab earlier, as there is more and more evidence that the use of tocilizumab is fairly safe if introduced early after CAR T-cell therapy. For example, this is a cohort of patients with that received axi-cell on the ZUMA-1. This is cohort 3. In this cohort, patients received prophylactic tocilizumab and steroids. Importantly, that the complete response rate and the activity of CAR T-cell was not different, suggesting that tocilizumab early introduction does not actually impair CAR T-cell activity. But what was significant is that the rates of severe cytokine release syndrome were reduced. It's a small cohort, but were reduced from 13% to 3%. But tocilizumab did not affect the rate or prevent the rate of neurotoxicity, which is known that tocilizumab does not help with reduction of neurotoxicity. So when in this cohort, when it was started prophylactically, the rates of neurotoxicity increased from 28% to 41%, was not statistically significant, but at least certainly you can confidently say that it did not lower the rates of neurotoxicity. And the fact that we do not have any therapy for neurotoxicity. In this summary, you can see that what we know that risk factors to increase cytokine release syndrome and increase neurotoxicity include higher disease burden, acute lymphoblastic leukemia, the deeper lymphodepleting chemotherapy, as well as using CD28 chimeric antigen receptor therapy. And that we know that tocilizumab helps with the cytokine release syndrome, but we do not have any effective therapy for neurotoxicity. B-cell aplasia is a common side effect. It's an expected side effect. CAR-19 targets CD19, and CD19 is on B cells. So it's what's called as on-target off-tumor effect. And that results in hypogammaglobulinemia that is easily managed with IVIG. However, again, we are uncertain what the role of IVIG after CAR T. Currently, it's being used and extrapolated from the CLL and bone marrow transplants literature. Also, because of B-cell depletion, the question is whether patients require reimmunization, and there is no clear answer at this point. The recommendations are extrapolated from the autologous bone marrow transplant literature. There is some data that the plasma cell immunity after CAR T cell is retained based on analysis from the University of Pennsylvania. So we'll wait for more data to see if patients really lose their immunizations and if revaccination is needed. Finally, to touch on relapses after CAR T cell therapy, what we learned in acute lymphoblastic leukemia that the most common mechanism of relapse is CD19 negative, is that the tumor loses CD19. It's an escape relapse. And in that case, the CARs are still around, but they do not recognize the tumor. And in acute lymphoblastic leukemia, the CD19 positive, where the tumor comes back the way it is about 1/3 of the patients. And here is the CARs are lost. There are intrinsic T cell problems where the CARs did not function as they should. However, in lymphoma, it's the other way around. Most relapses are due to loss of CAR T, and about 1/3 of relapses are due to antigen escape. And the loss of CAR T is usually associated with inhibitory receptor upregulation, and thus there are reports of synergy with checkpoint blockade to re-stimulate the CAR T, to reinvigorate CAR T. And a few antigen relapses are noted as mentioned. What we also know in lymphoma is that the CAR T cell expansion and their polyfunctionality are the most important predictors of responses. In this analysis by Rossi and colleagues from the ZUMA-1 study, you can see that the T cells that were polyfunctional, the T cells that secreted multiple cytokines, especially IL-15, at the time of infusion, patients having these polyfunctional T cells was the most important predictor of response, suggesting that T cell health is actually important, more important in especially in lymphoma. We don't know how to treat relapses, but it's clear that if there is antigen loss, then the CARs are still present. We need to try different CARs, and there are studies with CAR22, CAR20, dual CAR, triple CAR. But if it's antigen positive, which are the most common relapse in lymphoma, then the question if the CARs are still present and if there is any opportunity to re-stimulate the CAR, whether it's checkpoint blockade, whether it's immune modulatory, whether it's ibrutinib, you have to know that all of this should be done on a clinical trial if available. Also, there is the question whether retreatment is indicated, and so far the data is early, but what we have learned is that if the CARs are lost early on, perhaps that retreatment is not going to be useful, compared to that if the CARs persisted and had response and then lost. But this is evolving area and we continue to learn. So in summary, in lymphoma, the overall response rate is 60 to 80%. Complete response rate is 30 to 40%. Antigen negative relapse is less common, it's about 1/3. And possible role of re-stimulation of the CAR in cases of relapse. That cytokine release syndrome is related to T cell expansion. It's a capillary leak syndrome. The IL-6 receptor blockade tocilizumab is effective, and deaths have been reported. And neurotoxicity is associated with disruption of the blood-brain barrier. Myeloma, there is myeloid and T cell trafficking to the brain. Deaths also have been reported, especially if there are associated brain edema cases, and effective therapies are needed. Currently, there is no effective therapy. So we will stop here and we'll move to the Q&A session. Thank you all for listening.